Hello and welcome to Biotech Specialist webinar. In this webinar, we go to pediatric trauma. We have a surgeon from Hungary, Dr. Marcel Varga. He's with us live from Hungary, Budapest. Dr. Varga comes from Budapest National Trauma Center.
Yes. Thank you very much, and thank you for the opportunity that I can be here and I can talk about my favorite topic, and then I began my presentation. Greetings to everybody in this sunny afternoon. My name is Dr. Marcel Varga, and I'm working in Budapest. It is the capital of Hungary. And in this great hospital, we have a small department which is dedicated to pediatric trauma patients. We operate more than 1,000 patients yearly, and this number is growing. And more than 10 years of experience with biodegradable implants was the idea that we could make a webinar. So, a little overview: when we decide to operate a pediatric patient, we have many aspects and many expectations, how we should operate them and what are the expectations. So first of all, it should be a minimally invasive operation, because today the great approaches are over, or we hope so. In most cases they are over. It should be a very stable operation. So if we decide to operate the patient, we shouldn't add a very long additional casting. There should be no repeated surgery. It is always a very upsetting thing for the parents if they see that there will be a need for another surgery as well. There should be no long hospitalization. And one of the most important things, there should be no late complications. We who treat children from time to time, we know that a growth disturbance is always a possibility. Even an infection can occur in pediatric patients. And it should be well tolerated by the child. And today it is also a very important aspect that there should be a very early functional recovery because of the children, because of the parents as well. There are many conventional implants, and we can say that most surgery in pediatric trauma can be solved by these three implants. Most, 90% of cases, like screws, like titanium elastic nails and key wires, they could be used in more than 90% of cases. Of course, there are other cases as well when we need to use implants which are used in adult surgery, like plates, fixator external fixators, and other nails as well, but these are used less frequently. And this metal alloy, or we can say conventional, even a titanium elastic nail today can be considered as a conventional implant. So there are drawbacks, unfortunately. Like nails and screws should be removed, or at least can be removed with a second operation. We all know that key wires can cause many, many unpleasant complications as well, like superficial infections, like skin irritation, and key wire synthesis is not a stable synthesis. Key wires can migrate, and always, almost always, there's a need for an additional long casting, at least 4 or 6 weeks. To remove a screw, it is a controversial topic, but most pediatric surgeons like to remove the screws after half year, after 1 year, because we don't know what will happen with that implant if we let it in place for a long time. What will be the situation if there is another fracture, and that can cause also a problem later. Biodegradable implants are being used more and more, and the development has been going on for decades. I can say that we don't know which is the ideal material today, and the first generations of biodegradable implants had got many complications. The main complication was the bone resorption, and this has led to implant loosening. Today, there are two main types of commercially available implants. These are the magnesium-based implants and the polymer-based implants. Magnesium-based implants we don't have experience with, but they are not safe near the growth plates. This is the main cause we don't use them in pediatric trauma surgery or in pediatric orthopedic surgery. The polylactid co-glycolide is a relatively new material, not so new because it is well known more than 3 decades. And we have experience with this material more than 10 years since 2011. And until now, as we can see later, we haven't experienced any bone resorption or any adverse effects which was related to the material of this implant. So what types of absorbable implants do we have for pediatric orthopedic trauma surgery? Today, we have implants for screw osteosynthesis. We have implants for instead of key wiring. And hopefully, in the near future, we will have nails as well. And these can be used instead of titanium elastic nails for the time being in forearm fractures, but we hope later we can use them in other fractures as well. So which fractures could be stabilized with bioabsorbable nails? Here we can see a few types of fractures. These fractures we operate regularly with biodegradable implants. These are lateral condyle fractures, elbow fractures, distal tibial fractures, and many other fractures. And as we can see later, there are special indications as well, individually planned cases. The first of our patients were the elbow fractures. Lateral condyle fractures are very frequent fractures in children. It is always a question of debate. What is the optimal operation of these fractures? Of course, there are surgeons who like the minimally invasive closed methods. There are surgeons who like the open reduction. In our practice, we are always making open reduction and an anatomic reduction, and that was our old surgical operation with conventional implants. Then we used key wires and the tension band wiring to make a very strong osteosynthesis. And 10 years ago, we had the idea we should just replace these wires to the BioRetec ActivaPins. And here we can see a case when that was a great, severely displaced lateral condyle fracture, and it was stabilized by 2 BioRetec ActivaPins and a polydioxanone bioabsorbable tension loop. Here we can see a schematic drawing of the operation, but as the main drawback of this technique that these pins are invisible after postoperative X-ray. Only we can suspect that here we can see the signs. These are the bone canals when there are these key wires. And here we can see a video. Here is how we reduct the fracture. It is an open, small approach, an open reduction. We make the joint surface congruent. First, we use conventional key wire implants. We make the osteosynthesis, and in that phase of the operation, we choose the bioactive pin, and we replace the conventional key wires by these bioactive, biodegradable pins after a very accurate measurement of course. And here we can see when the pins are in the place, we use a polydioxanone suture to make a tension band wiring effect. And here we can see that this fracture is very stable and no tendency for redislocation. And after we place the pins with a special instrument, we burn the protruding ends. This is especially for these protruding ends, and there is no protruding ends, no implant outside to make a skin irritation. And medial epicondyle fractures also can be stabilized by this method. It is the same, of course, in this case, we use a medial approach, an open reduction, and again, we use these ActivaPins and the polydioxanone suture, and it heals perfectly. Here we can see an intraoperative picture, but it is not the lateral, it is the medial side. Of course, these protruding nails and are removed later. And here we can see the final picture of the operation. And here we can see the flexor muscles as well. Distal tibial fractures and epiphyseolysis are also a very good area for this type of fixation. Here we can see a distal epiphyseolysis, and it was stabilized with a bioretex screw. Nowadays, we are always using a postoperative CT scan to see if the position of the screw is optimal. Here we can see a perfect reduction, no fracture gap anymore. And of course, it is the healed picture, no sign of any implant, or perhaps we can see that there is some remnant of the screw after half year of the operation. And there is a very special technique for distal forearm fractures. A few years ago, our department has published a new technique. It was called distal short intramedullary nailing of distal radial fracture. The main essence of the operation is that we stabilize the distal and very severely dislocated fractures with a short and pre-bent intramedullary nail. And the main point of this operation that it is very stable, no need for a long casting. And 1 year ago, we had the idea that we can replace this conventional titanium implant into a very thick and very short bioactive pin. And this bioactive pin, as an off-label use, is inserted in an intramedullary way. Now we have more than 30 operations, and we have seen very good results, no skin irritation, a very stable osteosynthesis, and no need for additional casting. Here we can see a 9-year-old girl with a severely distal forearm fractures, and here we can see the postoperative pictures as well. Another case, a 7-year-old boy, it was an isolated distal radial fracture. It was stabilized by this intramedular, very thick biodegradable implant, and it healed perfectly. A 9-year-old boy with an Ogen 2B displaced fracture, we can see here. And in his case was a very difficult case because first we didn't know how we can fix this fracture. And even in his case, we were able to stabilize the fracture with 2 very thin intramedullary bioretex pin. Here we can see the postoperative CT scan as well. Laurie, you hear me?
Correct. Everything is good.
Okay,
Thank
because
you. Please
I don't
continue.
see you anymore. Thank you.
Very interesting.
And osteochondral fractures as well can be stabilized by bioactive pins. This was a great osteochondral fractures due to a patellar dislocation. And here we can see the fragment, and we resutured it, and we stabilized it with 5 very thin bioactive short nails, and it healed as well. It is always a question, what about bone hydrolysis and resorption? Because many surgeons fears of these effects. Here we can see a talar fracture, which was operated 3 years ago. Here we can see the postoperative MRI scan. Here are the pins. And 1.5 years ago, we can see that the implants has shrinked. These black dots are the original implants, and these white circles are the original bone canals. So no bone hydrolysis around the bone canals. So I think it confirms that no additional bone resorption occurs. And after a few years, we can see that this bone canal will disappear as well. Here is a post-operative MRI scan after an operation. Here is the picture after 1.5 years. We can see again the black dot. And after 6 years, no sign of these bone canals anymore. So these implants indeed disappears from the bone totally. And there are special cases as well. These are not standard indications. Sometimes we are always in problem what we should do with a patient like him. He was a 16 years old adolescent with coagulation disorder. If we see, according to AO, we should make an open reduction and the plate osteosynthesis, but in his case, we can see also that the growth plates are open and still he can grow. So we decided we try our minimally invasive intramedullary technique with biodegradable implants. And here we can see the post-operative picture. It was really a minimally invasive synthesis. Here we can see the post-operative CT scan as well. And here we can see it was stabilized by 2 nails, and the reduction is perfect. Of course, in his case, there was a need for a 4-week additional casting, but it was a short forearm cast, not a long above the elbow cast. Also, a special indication is the tibial tubercle ventro-medialization with active screws. This operation we do because of patellar dislocation or due to anterior knee pain. And the advantages of this technique that there's no need for screw removal, and the heads of the screw doesn't cause any skin irritation, which is a frequent complication of this operation. Here we can see an operational video. After ventro-medialization, we make a key wire temporary fixation. We simply over-drill these key wires, so the technique is the same as in the case in a conventional implant. We make the threads as well, and after that, we choose a screw after accurate measurement, of course, and we insert the screw. We can see it. It is a very simple technique. There's no difference, not else than a conventional implant. And after we inserted the screw, with this special device, we remove the head of this insertional device. And after the operation, we can see that the ends of the screw are in the level of the bone, and it is a very stable osteosynthesis. Even in our practice, of course, it can be debated, but we don't use any removable brace after distal tibial tubercle ventro-medialization because it is a very stable osteosynthesis, even with these bioactive screws. And there are other indications as well. It was a 9-year-old girl with a very dislocated distal crural fracture. And in his case, we again used the short elastic intramedullary technique. First, we made the operation with conventional implant. After we removed the implants and we replaced them by these invisible, very short, very thick bioretic pins. And here we can see the post-operative picture of his leg. It was really a minimally invasive operation. Of course, in her case, also there was a need for a brace or a cast treatment because we didn't think it was a very, very stable synthesis, but it would have been the same if we use a titanium elastic nailing as well. And it was also a very interesting case, an 18-year-old man. He is almost a man, but we can see his growth plates are open, but he has suffered a total distal epiphyseal separation. In his case, of course, there is a need a perfect anatomic reduction, but we thought that we use conventional plate only in the case of the radius. And this epiphyseal separation was operated by a minimally invasive way with a bioabsorbable implant. So when we have to remove the plate, we don't need to go back to this area. We have to remove just the plate. And in his case, it was also a very stable synthesis. A young adult, a second metacarpal neck fracture. He suffered. These operations were done earlier. And in his case, it was again a minimally invasive and intramedullary osteosynthesis. And we can see we achieved a perfect anatomical reduction. Of course, we were not so brave then we let it without a plaster cast, so we used a few weeks of plaster cast as well. So here we can see our results between 2011 and 2020. As we can see, we have regular uses, distal tibial ankle fractures, distal forearm fractures today are general practice in our department. And there are many new areas like hand, like tibial, tubercle, ventro-medialization. And there are special cases, special indication when also we can use these biorethec implants or these biodegradable implants. Until now, so far, we haven't observed any septic complication which were related to these implants. We haven't seen bone hydrolysis. We are making more and more MRI examinations postoperatively to see if indeed these implants are resorbing. And until now, we needed 2 reoperations. These were not true reoperations. There were 2 patients who had skin irritations, but these were rather surgical errors because we left a very long protruding end of these implants and they caused some skin irritation. We just cut the protruding ends of the implant and this skin irritation has disappeared. And we have seen only 1 refracture. This was after a tibial tubercle ventro-medialization, but it was a new accident. After 6 weeks, this little girl was falling from the staircase and she suffered a new fracture. And in her case, we removed the screws. There was no problem with screw removal and we replaced them by conventional metal. So there are important notes. I think currently there is no evidence of the superiority of biodegradable implants because we can find only small case series in the literature. So we have limited experience of the long-term results. Today, there are no clear indications when we should use bioabsorbable implants instead of conventional implants. I think it is always an individual decision which is required for each patient. Sometimes the surgical technique is more difficult than a conventional technique, and the surgeon should always have the option to convert his operation to conventional way because there can be problems, of course, mostly in the learning curve period of this new technique. And I can say that these implants are not so strong than conventional metal implants. So in cases when we think that a very strong osteosynthesis we need, perhaps we should decide of using conventional implants. I think biodegradable implants cannot be used for every fractures, but we believe that their use will become more widespread in the future, and I hope that that will be the case. Thank you for your attention. I hope you are still with me.
What an interesting presentation. There are lots of questions on our live Q&A. The implants are not visible in postoperative X-rays. How do you know that they are in good position?
Yes, this is one of the main drawbacks of the technique, and there is a need first a conventional implantation, and then we have to make a very accurate measurement. So after we have done it, we simply replace the biodegradable implants to the conventional implant, and but this is a very hard thing. So it requires a very experienced surgeon. But in the future, in the near future, I think there will be bio-labeled implants as well. And perhaps it will be a great development when we will see these implants. And I can say it is not totally true that we don't see at all these implants. A small shadow they cast even in the fluoroscopy. So something we can see in the fluoroscopy as well.
Okay, thank you very much. Another question, or actually a few questions regarding, there was this bending section, I think in the distal radius fracture. How about the bending? The questions are asked that, is it difficult, the bending? How do you do it? Is there some special tricks to do
Yes,
it?
this is one of my favorite topic, and here is the place of a little advertisement. There will be a whole individual webinar about this technique, about distal forearm fractures, but you should bend the nail to a C shape, or at least a C shape or a half moon shape. But first, you have to do the operation with a titanium elastic nail. And if the reduction is perfect, and then you should form your bioretic implant to the same shape as with the titanium nail. If the reduction is not perfect, then you should remove the nail and you should rebend it to the degree which need. So it is not a very easy technique, but after you have got some experience with it, you wouldn't like to do anything else.
Okay, that's a nice comment. What about the learning curve? So you mentioned earlier that there's a little bit learning curve with the implants. How long learning curve do you think it is?
It depends on the surgical area and the surgical technique. If you choose to operate this tubercle ventro-medialization, and if you are an experienced surgeon in tubercle ventro-medialization, there's no learning curve because the technique is the same. You just use biodegradable screws instead of conventional implants. And of course, there are other indications as well. For example, the distal forearm fractures, there is a great learning curve because this is a whole new technique. Until now, we don't have great number of cases, so I cannot say which long the learning curve is. But what is the most important thing, the surgeon who chooses a biodegradable fixation, he should be experienced in pediatric trauma surgery, and this is the most important thing, I think.
You mentioned that you have not had any septic complications. That's true?
Okay, I think in pediatric trauma, one of the most important complication, or not the most important, the most frequent complication is skin irritation. Key wires and elastic nails are always doing skin irritation. It depends on the surgical technique. It depends how long the protruding ends will remain there. And if we don't use a very accurate technique, we left a very long implant under the skin, even it can cause irritation. But these two cases, I think, was rather a surgical technique in the early area when we didn't know exactly how we should remove these protruding ends. With this implant, with this special device, special burning device we have seen on the video, it is not a problem anymore because we can burn any protruding ends, even 1 millimeter.
Okay, and you're referring here to a hot loop.
Sorry, it was just a subjective irritation, not an infection irritation. I think it is very important.
Okay, thank you. And you're referring to hot loops that we also have available in our portfolio. Then regarding the post-operative treatment, you had sometimes you use cast, sometimes you do not use cast. Do you have any recommendations of the basic post-operative protocols you use?
It again, it depends on the surgical technique. It depends on your decision. After an operation, I think every surgeon should know how stable his operation is. Usually, there is a protocol in the case of distal radial fractures. In these fractures, we use a short cast for 1 week, and after we change it for a removable brace for 3 weeks. So altogether, only 4 weeks of some kind of immobilization, but this removable brace is very comfortable for the child. Other indications like screw osteosynthesis, postoperative protocols are the same as with conventional implants. So if we choose a plaster cast in the case of a conventional, after conventional screw osteosynthesis, we will choose a plaster cast after a biodegradable screw osteosynthesis as well. So no difference.
Okay, I think that's a good principle on
just
that.
the principle, because every fracture differs. So we can talk about later about it, but it is a general principle. Yes.
There are a few more questions. Which size of ActivaPin did you use in the epicondyle fracture treatment? Was it 2.7 or?
Mostly 2 point, or in some cases 2.7, but mostly the 2-point diameter pins we use. This is not the smallest, but this is thick enough, but not too thick. If the child is older, then perhaps a 2.7 diameter can be, but usually the 2-point diameter we use.
One question is also regarding the expensiveness of the implant. What do you think about that compared to traditional metal implants?
Yes, I was waiting for this question already. Yes, it is always a question, and every surgeon asks me, but these are more expensive. Of course, these implants are much more expensive than a conventional implant. But if we see the overall cost is that in most cases, or almost or all of the cases, no need for a second operation, and the outpatient visits dramatically decreasing, I think the overall costs are much more cheaper than a conventional operation after a second operation, implant removal, and perhaps a complication of the implant removal. So I think when we see the long-term cost, it will be much more cheaper, but of course, it has to be confirmed.
Okay, thank you. How many non-union cases have you had with bioresorbable Activa implants?
Until now, so far we haven't seen any non-union cases, but we operated non-unions, so primary non-unions. For example, the boy who have seen on the video, he had an old non-union of lateral condyle fracture, and the non-union was operated with bioactive pins, and it has healed. So we operate non-union, but we haven't seen non-union due to this technique.
What about you fixed fragments through physis? This is very dangerous topic to go, but this is asked here. So do you fix fragments through physis?
Yes, it is a very dangerous topic. We usually avoid physis. We wouldn't like to touch the physis. We are very afraid of physis. I've shown only one case when we went through the physis. It was an 18-year-old boy, because in his case, I think no other option, and he won't grow anymore. But in the case of distal forearm fractures, we always avoid the physis. We never touch it. We are usually near the physis, but until now, we didn't see any physis arrest because of this technique. But this is a very strict rule in our department. We should never ever touch the physis, only in rare cases.
In the distal radius fracture treatment, what is the instrument that you use to help the bending of the pin?
Just my hand, or the same. The principle, the instrument is the same as we use in elastic nailing. So no other instrument we need. And I'm very glad that there are many questions about this distal forearm fracture. But again, I can say there will be a whole webinar about this technique. But we use the same implants, or just my hand. We can bend with a free hand these nails, as well as titanium nail can be bended with free hands as well.
All right, thank you very much. I think the time is almost up. I want to thank Dr. Varga very much for your presentation. It's very important that surgeons around the world get the first-hand experience on how to use bioabsorbable implants Thank you so much, Dr. Varga, for
Thank
having
you
this
again.
meeting.
Thank you for the opportunity, and I wish everybody a nice weekend. A nice week. Sorry, this is the end of the week.
Thank you so much. And please remember to follow Bioretech's LinkedIn and Facebook. Thank you again. Hope everybody will be safe and will continue after the summer. Thank you very much. Bye for now.
Thank you.